Well, thank you very much. Those were excellent presentations. At this time, I'd like to open it up for questions. Go ahead. Oh,
You don't think it's on?
I'm sorry.
Oh, you need. Take it away.
Hi, my question is for Dr. Davis. So I was curious about the educational component of the intervention. How was that delivered? Was that via video or was it recorded information?
So most of the educational content was like PowerPoint, but it was very short. We did do some videos. Some of the videos were box videos, canned videos from the company, but we did do several of them ourselves. So they would actually see their RN care coordinator at some point in time, you know, actually delivering the content. So we used various ways to deliver it, but it was all delivered through the tablet.
So did you get any feedback from the participants on which type of, I guess, media they like to receive that information?
We did get some feedback on that, though, but because everybody's getting pretty much the same thing, we know that we have to keep it a mix because every individual learns differently. And then also, we didn't want them to get bored with it. Like, if it's all PowerPoint, they're going to get bored. If it's all video, they're going to get bored.
In follow-up to that, when you did the follow-up phone calls, was there teaching involved in that? And if there was, did you capture those data as well?
Yes, there was teaching involved. So if a patient had a violation and the nurse had to call that patient, they actually documented that into the dashboard. Health Harmony is the platform that they use. They would actually have to document what they reinforced. That also allowed them to push out. We could push out additional education. So if we found that there was a patient that we were calling almost weekly and it was almost always directly related to nutrition, then we could send that patient more modules, you know, on nutrition. And also there's a library inside the tablet, basically, so they could actually browse the library and go over additional education at any time.
Thank you.
I had a question for Jamie Kissee. Thank you for your presentation. Were all of the patients seen from a local rural hospital? I'm kind of curious about who was making that choice between telemedicine and telephone.
So were all of our hospitals rural? Is that?
Were the originating sites all hospitals, and was it a nurse or a doctor at that hospital when assigned to call in said, no, we're going to make it a telemedicine visit?
So all of our consultations are conducted physician to physician. So they were physicians on both ends, and they were mostly rural and underserved. There were 2 urban-based hospitals that were included.
2 urban?
2 urban, mm-hmm. Yeah, the other 14 are rural.
I think just picking up from that, did you get a sense for, because I realize that either physician could decide, I want to use what was not recommended. Did you get a sense for, did it often come from your own physicians or did it come from the community side to go against the recommended technology?
Yeah, so it's interesting. I would say that depends. That's not really an easy question to answer. It depends a lot kind of on different factors. So how this study is structured is that our physicians at UC Davis, they're the ones really in charge of pushing kind of like, hey, I'd really like to see this kid over telemedicine. That's typically how it works, just because our physicians do it so much that they're used to it, they're comfortable with it. Where any physician, even if we've had this partnership with these rural hospitals for quite a while, it's not as likely that they're the ones calling in. But again, that doesn't go for all of our hospitals. There's one hospital who, it's funny, they were recently, over the past 6 months, assigned a telephone. almost every time they called in, they're asking for telemedicine. They're so comfortable with it. They really enjoy it. So, it depends. There's clinical reasons that are driving this, but then there's also these partnerships that are driving it too, and kind of their comfort level with requesting it or not. So it's really coming from both ends. Our physicians have definitely recommended telemedicine before, where the outside hospital is saying, hey, I don't want it. That we see that too. So it's coming from both sides.
Thank you. I have a question for Dr. Davis. Well, before I do, you all are doing some really cool research. But anyway, so Dr. Davis, you said a 12-month duration for the study was a little bit long for the patients. It sounds like they had a little bit of fatigue hooking themselves up to a machine every day. So I was curious about what your sense is about what you can do to kind of take this technology forward. I mean, I know you talked about monitoring transplant patients, and so, obviously this is something you'll want more consistent follow-up for a couple of months afterward. But then, especially for your diabetes patients, especially because that is such a big health concern in Mississippi, is this something where maybe they only get like a weekly kind of monitoring thing? I mean, what are your thoughts?
Yeah, we actually have shortened it. So the live program, the actual RPM program, is 3 to 4 months. However, the provider and the patient can determine whether they want it shorter or whether they want it longer. Oftentimes, the payer is going to dictate how long it can be. Some of them will approve it for 6 months, but if a patient is on it for 3 to 4 months, we know that we'll get good results, because it takes about that long. Remember, it's about behavior change. We don't want to be a crutch to the patient, and we know that it takes about 3 months, to see any kind of behavior change. And they stay engaged, and it's honestly about that much content, for them to receive without getting burnt out with it.
I was just going to ask Jamie, so you said you're going to kind of delve more into, what the reasons were for why the physician. So I guess, do you have a sense that if there are clinical reasons, will that change or maybe support your conclusion about the telemedicine allowing you to avoid transfers and things like that? Or is it possible that they were, for some reason, less severe when they got the telemedicine and so wouldn't have gotten transferred anyway? Or?
Right. So, yeah, we're going to be collecting additional data. And we actually have been over the past 2 months we started this. So I can kind of give you an insight into the type of feedback we've been receiving so far. There will be clinical reasons that we'll be looking more into what kind of clinical diagnoses that they're calling about, which we haven't looked at yet. But hopefully that'll provide us extra insight. But right now, just the initial feedback, it's either sometimes that our physicians and our pediatric or neonatal ICUs are too busy. They get the call and they're like, hey, I'm crazy on the ward right now. I just don't have time to sit down and connect over video. We're seeing that. Every now and then we see a technical issue. We have a tech team that's 24/7, but sometimes they run into a tech issue and it's just easier to pick up the phone to call. We have seen, the remote ED just not being interested. So we're seeing, so those are the main reasons that we're seeing right now. We also have seen too that that specific physician wasn't aware of the protocol at that time. Oh, I didn't know this site was on telemedicine. We do everything that we can to set reminders around. So that's what we're seeing right now. But hopefully, as we collect this data throughout the past year, we can really identify these issues, and then also the clinical diagnoses that we're seeing as well. So when and what clinical situations are we seeing telemedicine happen more often or not? Is it the more severe cases or is it not? Because we definitely see both. We see really severe kids that the ED will really want a telemedicine consult. We've had really great experiences with that, and then we definitely have the non-severe kids that are getting these telemedicine consultations, which is great because then our physicians can keep them in their community. So we see it on both ends, but so we'll see what the data show.
Tearsanee, Your patient panel, were those, you may have mentioned this already, were they all newly diagnosed diabetic patients, or were some of them already established, or what, do you know what the mix was?
I don't know what the mix was right off, but I do know that they weren't all newly diagnosed. It could be at any stage in the process.
Hi, Dr. Davis. I have a question about reimbursement. You said there's a range. I was just curious to know what the payers, the insurance payers, were willing to pay for this service. And I'm also curious about the folks who don't have insurance. So how do their services get paid, or how are you getting any reimbursement from those folks who are Medicaid or Medicare patients?
Okay, so Medicare does reimburse, Medicare and Medicaid do reimburse, and then the private payers reimburse as well. I will tell, Medicare reimburses the lowest because we have to use their chronic care management code in order to do it, and it's not much, it does not pay for it at all, not even close, but it's the right thing to do, so we do it for those patients. And then the other payers, we get, that's roughly $500 a month, because there's a daily monitoring fee that's associated with that. And we haven't had much trouble with any of the other payers. Medicaid has actually been really good about paying for it. Also, Medicaid, and then the other, well, Medicaid pretty much specifically, they do require the two hospital visits within the past 12 months for that disease state. And a hospital visit could be an ER visit or an inpatient visit. Whereas Medicare, with chronic care management, it's just 2 chronic diseases, and they pretty much pay for it. We have found, though, that some of those who don't fall into that category, if we appeal it, if we send it through because the provider asked us to send it through, and we ask them, that they'll pay for it. Now, those that are uninsured, we are finding where some of our hospitals and some of the clinics, and they choose to pay for it for their patients for a set amount of time. We've also had some success with some of our employers who participate in our corporate telehealth program. They actually have identified some employees that are high risk for hospital visits, increased healthcare costs, and they've come to us and said, hey, what can you do for this patient? And we've presented it to them, and they've determined, well, we'll pay for it, for that set amount of time. So we even write grants and get funding and say, okay, we can afford to put, this many patients on this program if they qualify. But we need that data, so that's why we're doing it. So we can go back to the payers and say the criteria is too tight. We've got all of these people that, my dad is one of them. He's diabetic, but he hadn't been in the hospital in 30 years, for anything. But he would benefit from this program. So we're actually trying to capture those people, those groups that reimbursement doesn't cover, so we can go back to the payers and say, let's look at what about these people that don't meet the criteria but are still, would still benefit.
While you're taking the microphone, I have a question for you, Dr. Lowery. Your findings were very impressive. Were there any economic impacts to this? Does it cost more to be doing these ultrasounds remotely? And did you collect any physician or patient satisfaction data? Although you were retrospective, so probably not.
Well, no, we've done that before in other projects, and the patients like it and feel comfortable doing it. We run it really pretty much like a clinic at the school. The genetic counselor comes into the call and counsels the patient just like they would at the school. It has provided an increase in number of patients that we can see. The volume doubled basically because we were limited with the amount of machines and ultrasonographers that we have. Some of the ultrasonographers around the state, we have between 25 and 30 sites that we're doing this in. Some of them are our people, and they either take mobile ultrasound with them, or they use the hospital facilities. And then we use some ultrasonographers that are at hospitals and the hospital's ultrasounds. Largely, most of these are done in hospital sites around not all. In Fayetteville, we established our own sort of ultrasound prenatal diagnosis clinic in that area, but a lot of the other ones are most of them are in the hospitals. So, I think you might look at it as that we expanded our capabilities and we make accessibility of the patients much easier rather than driving. It's particularly of benefit in the patients that we had to follow chronically. Like an example would be RH isoimmunization, in which we have to monitor the status of the fetus. And so those are now done remotely, as opposed to in the past we had to do a weekly visit with those patients. So,
Did you find that you had to do more repeated ultrasounds than would be typical in conventional applications, or did you really not see any difference?
Not really. I think we over the years we've adapted to it. Our big problem is we're doing too many ultrasounds in general, and it has to do with the physicians feeling they need to see all the structures. And I think one of the things over the next, we do healthcare reform, we're going to have to really start thinking about, well, does it really make any difference if you've seen all the fingers on all the hands? What impact does that have? And our doctors actually, even though we're all MFMs, vary in the terms of how aggressive they are making the ultrasound. So we're going to standardize, what's enough, and is it worth really bringing a patient back 3 times because you couldn't see the left hand adequately. So that's going to force us to adapt to again, in a fee-for-service world, you just got paid more fees in a way, so why would you not do it? And that's no longer true.
Right. Thank you.
I just had a quick question for Dr. Glassman. So do you have any kind of data about how your satisfaction for your in-office patients, or do you have a sense of whether they would prefer telemedicine or are indifferent? Or?
So, we get Press Ganey data, and we do have very high provider satisfaction. The office satisfaction tends to be a little bit lower, just unfortunately due to some of the patient throughput and things like that. If I had to guess, we've never done a direct a comparison. That's certainly something that I think we need and should do, but if I had to guess, I have a feeling that system satisfaction would be higher with the telemedicine than with the actual office experience. I don't think provider satisfaction would change significantly.
I have a follow-up question for Dr. Glassman as well. I am interested if you expanded more with the patients who received a bad diagnosis through your method and what their thoughts were related to that. We get a little bit of questioning with our high-risk OB program related to, well, what if we tell them their baby has a congenital anomaly or something? So what if your patients that received the cancer diagnosis or something like that?
So the patient themselves, there's been very few, I will tell you that, but the patients themselves have not been unhappy receiving that news via telemedicine, especially if they were coming. We do have some patients who live 3 hours away up in northern Pennsylvania, and so they do come a distance. So for them to avoid that 6 hours of travel is a benefit. The patient's wife was not happy, but the patient himself did not have a problem at all. But we have heard from spouses saying, how can you do this not face-to-face and things like that. Our office has a policy of generally not delivering pathology results via phone, just sort of for that reason. We'd have to see how it plays out, and it'd be, more with our telemedicine experience. It's very limited in those cases right now, or we just don't have the numbers.
Hey, everybody, it's Brendan Carr from Jefferson. I had a question, but I just wanted to comment on that. We had some qualitative work that popped up, this idea that folks said pretty clearly, it's qualitative work. It was a couple, it was not the focus of the question. It's not the gospel, but they said, I would much rather get bad news in my house with my husband, turn off the computer and have a conversation about it, than go face your waiting room, face the parking attendant, face traffic, get home. It was interesting because we didn't expect it. I worried a lot about that as well. But my question was, and we touched on it a little bit. A lot of the dialogue that we're having today is about cost reduction from the payer side, and it's interesting to hear Kurt say that we don't live in a fee-for-service world anymore. We kind of do still live in a fee-for-service world, and most of what all of you are doing is stealing money from San Diego, I think, right, by not bringing in these kids, and maybe Jeff, if you can't bill for, and down the road, avoiding emergency department visits. What are you thinking, right? This is bad business. Why would you not want that third or fourth ultrasound? Just for clarity, I'm on your team. I, of course, agree. But I'm wondering if we could maybe have a little bit of a conversation about the financial disincentives to think like this, what you're feeling from your health system, whether or not you ever get pushed back about whether or not you're stealing from them.
Well, again, I said at the meeting, one of the unique areas, the problem right now in a fee-for-service world, a lot of this stuff doesn't work because of the reason you just said, which is you are taking away, you put tendrils in a place that allow you to suck patients out of the local environment. There are things where it does work, and so high-risk OB is one of them because pregnancy is a normal physiological process. Most of the general OB/GYN and family medicine guys are used to taking care of routine people, and so they lose money in a way on taking care of a sick pregnant woman because they take a lot more time and you don't get paid anything extra for taking care of that patient. So they really don't hesitate to get rid of those patients. That's bad for tertiary care centers because now you have a large volume of really ill people and you get paid basically the same amount of money. But we got Medicaid to fund angels in the very beginning to accomplish just exactly kind of what we did with the program. Now, I think until we really move forward into like a distributed payment structure where we're going at risk and doing population health care delivery, there are always going to be struggles. Another area for which it works is stroke for similar sort of reasons that, most small hospitals don't have a vascular neurologist. So when you can hit on things that are unique, fee-for-service world, still you can do it. But if I throw a rock outside the window, I'll hit a cardiologist on the head. So if you think you're going to move adult cardiology stuff around, it's probably not going to happen because they do see it as competition. So, I think, but Walmart has told me they're not paying the same amount of money for health care. And when Walmart tells you something, you better listen to it.
Yeah, for us, of course you meet resistance. Especially in the primary care world because they don't believe that fee-for-service is going away. And so when we approach them, our approach is it's going away, and we're just trying to help you prepare for that. They still, don't refer a lot, but our healthcare system, we are the tertiary medical center in the state, so we're going to get these patients if they continue on the path that they're on. So we've gotten a lot of support from our hospital. We don't want the patients to come back into the hospital. We have enough with all of them that we have across the state because we take care of the smaller facilities that do want the patients to keep coming in the hospital. When their patients get worse, they're going to end up with us. So we want to take care of those patients, and we've had our upper-level leadership support us very well with that in our performance improvement departments. They've come to us, as she mentioned, how do you handle the uninsured? We take care of a lot of uninsured. Our hospital has said, we're getting the penalties from these patients coming in and out of our ER and in and out of the hospital. We'd rather take that money and pay for these patients. To be on this program. So yeah, there will always be pushback. We know that. I think the key with telemedicine and what has worked for us in Mississippi is we create our programs based on a real need. This is something that a provider, a health system, somebody on the outside, not UMMC Center for Telehealth, has come to us and said, this is a real problem. Can you help us with that? And so at least then we know we have some buy-in from groups. So it's not just, us thinking of a great idea and trying to force it on people. It's a real tangible problem that we're addressing.
The other thing, and we've been talking to them as well, is DRGs, right? you have a number of days per diagnostic code. And if you go over that, you lose money. And so if you can use this stuff to get them out of the hospital, they can open that bed up for somebody else for which they're going to get paid for. So they like that very much. So
I think we could continue this discussion all day. We have time for one more question.
So this is a challenge and not a question, because I'm trying to take Elizabeth's comments from yesterday and say, how do we as Search, as a society, put together data and something that's useful to make decisions? And I'm sitting there, you can't get a more heterogeneous panel. You know, we got a bunch of pregnant moms, a bunch of probably middle-aged diabetics, we got old men with prostate cancer, and then we got little kids in hospitals. But I think I came up with it. And so this is my challenge for everybody in the room. The four of you could actually work together to sort of do Deb's paper, which is satisfaction, which all of you are collecting, related to the distance from the hospital or the transfer being avoided. That data is not really out there in a robust area, and everybody's bias is that there's a bigger problem in rural areas, and we know that there's a problem in rural areas. There's no providers in rural areas. Turns out there's no appointments in urban areas, and so we all have problems. And so, you know, we had Picori here yesterday, and this is really about finding a patient-centered solution. It would be worth knowing, in the patient's mind, is it a bigger problem for people hundreds of miles, or in Steve's case, 1,000 miles from their institution? Or is it not? And I think, you know, the four of you who couldn't be more dissimilar in what you presented could all work together to answer that question. So I put that out there just to stimulate discussion the rest of the day and say, how do we take things that we're all doing and come up with one piece of data that is really, really powerful?
There's one more question?
it's worthwhile.
Okay, before I introduce the next moderator, coming from a very large healthcare system, I just want to say that we have an obligation to be at the table to make these arguments, because if we're not at the table, we're going to be on the menu, and I don't want to be on the menu.